Hey guys, welcome back to my channel. So today I'm going to start with the 4th semester Pharmacology 1 question and answers as per RGUHS question bank. So today I'm going to start with the new unit, second unit, General Pharmacology. Then long essay. The first question will be write the principle and mechanism of drug action. So the principles of the drug actions, it alters the pace of ongoing activity which doesn't impart the new functions, and the types of the drug action are stimulation, depression, irritation, replacement, cytotoxic action, antimicrobial action, modification of immune status. So I'll start from the first one, that is stimulation. So the selective enhancement of the level of activity for the specialized cell, where example adrenaline are the effect for the heart. And number second, that is depression. So the selective diminution of activity of a specialized cell, example barbiturates which affects to the CNS, and quinidine which is affect to heart. So certain drugs stimulates one type of cells and depress the other, like example acetylcholine. And number third, that is irritation. So the non-selective noxious effect has less specialized cell and mild stimulate function it occurs, example bitters increasing salivary and the gastric secretion, where the strong inflammation occurs due to the toxic effect of the specialized cell for corrosion or necrosis, etc. So fourth one, that is replacement. So replacement is defined as the use of natural metabolites, hormones or their derivatives in the state of deficiency. So the example are iron is used in anemia. And number fifth, that is cytotoxic action. So the cytotoxic action is the action on cancer cell or on growing parasites without significantly affecting the host cells that are used for the diagnosis of infection and neoplasms, example penicillin, zidovudine and chloroquine. And number 6, that is antimicrobial action. So the prevention, arrest of eradication of infections. So acetylcholine specifically on causative organisms, example antibiotics. And number 7, that is modification of immune status or immune system, where the enhancing or depressing the immune status, like vaccines, sera, corticosteroids are the examples for modification of immune status. So the mechanism for the drug action, majority interaction with the discrete target molecules, proteins, where enzymes, ion channels, transporters and the receptors are the mechanism for the drug action, where the enzymes are complex structure proteins that are produced by the cells and act as a catalyst in the specific biochemical reactions. So the drug can either increase or decrease the rate of reaction in the mediated by the enzyme, where example adrenaline stimulates the hepatic glycogen phosphorylase. And number second, that is ion channels. So these are present on the membrane of the cells and they allow the ionic movement across the cells from and into the extracellular fluid. So the ion channels respond to their specific ion. Each drug modulates the opening and closing of the ion channel, where the drugs act on the ion channels by directly binding to them as the movement of the ion occurs. Where so the types of the ion channels are ligand gated ion channel and voltage gated ion channel. So the example are quinidine blocks the myocardial sodium ion channels. So ethosuximide inhibits T type, that is transfer type calcium ions channel. So number third, that is transporters. So many drugs interact with the transporters and bind with them and show their specific actions. So they are also known as carriers. Example, furosemide inhibits the sodium, potassium and chlorine co-transporter in the ascending loop of Henle. So hydrochlorothiazide restricts the sodium chloride sympathometer in the distal tubule. Where number 4, that is receptor. So the receptors are the cellular structure composed of proteins that are postulated to exist in order to mediate between a chemical agent that act on the cells and gives the physiological responses. So receptor does not have their own functions, and receptors are macromolecules having a large complex structures. So most of the drugs do not bind directly to the effectors. So coming to the next question, that is question number 2. What are G protein coupled receptor? Explain about G protein coupled signal transduction mechanism. So G protein coupled receptor are also known as 7-pass transmembrane domain receptors. So 7 transmembrane receptors, heptatical receptor and G protein receptors form a large group of evolutionary related to the proteins that are cell surface receptors that detect the molecules outside, and the cell activates the cellular responses, and they are called as 7 transmembrane receptor because they passes through the 7 cell membrane. So mechanism for are an external signal such as ligand or another signal mediator activates the G protein coupled receptor. So this causes a conformational shift in the receptor resulting in the G protein activation. So the type of the G protein has an additional effect for the G protein, and they are inactivated by RGS protein, which are GTPase activating proteins. In that, number 1, ligand binding. So G protein receptors have one or more receptors for following ligands: sensory signal mediators, adenosine, montans, bradykinin, endothelin, GABA, hepatocytes, growth factor, orphan receptors of growth of receptors of GPCRs that serve as a receptor for stimuli and that they have yet to be discovered. So G protein receptors ligands, on the other hand, often bind within the transmembrane domain, unlike where the ligand attached outside to the membrane. Protease activated receptor on other hand and chemotriggers by the cleavage for the proton for their extracellular domain. And the number 2, conformational changes. So the receptor signal transduction through the membrane is not totally understood by the G protein coupled receptor is known to be linked to a heterometric G protein complexes in its inactive state. So when an agonist binds to the G protein coupled receptor, the receptor undergoes a conformational shift that conveyed to a bound G subunit of the heterometric G protein through the protein domain dynamic. In that, signaling, the signaling pathways are activated by G protein coupled receptors are concentrated by the GPRS primary sequence and tertiary structure, but are ultimately controlled by a conformation maintained by a particular ligand and the availability of the transducer molecules. So in that, number 1, G protein dependent signaling. So there are mainly 3 main G proteins mediated signaling pathways. Each mediated have 4 subclasses for G protein: G alpha S, G alpha IO, G alpha Q11 and G alpha 12 and 13, which are characterized by the sequence of homology, and these classes are defined by the isoform for the subunit because the signal transduction properties of the differential potential combinations do not appear to differ much, and while the G protein coupled receptors are capable for activating the multiple G subtypes, so they have to preference for one over the other. Even the functional selectivity of the occurs GPCR, however, because they any signals agonist may be GPCRS, GEF, and domain maintained during the course of the signal contact. So it may also be trigger the activation of numerous different G protein. So the GPCR is preferred coupling partner in usual determined by the G protein is mostly clear activated by the endogenous ligand and in the most physiological or experimental situations. So number second, that is G protein independent signaling, where the G protein coupled receptors may be communicals through the G protein independent methods, and the heterometric G protein may be performs functional roles independent of GPCRS, and despite the fact that they are traditionally assumed to only work together, so many proteins already listed dependent signaling such as ARRS and GRKS and SRCS may signal independently through the GPCRS. So example, arrestin signal mediated by the chemokine receptor, so CXR3 was found to be required for full activeness and chemotaxis of activated T cells. Further, the proteins involved in the GPCR subcellular localization. And coming to the third question, that is what are enzyme link receptor? Explain the tyrosine enzyme link receptor signal transduction mechanism. So an enzyme link transmitter is also known as catalytic receptor. So it is a transmembrane receptor where the binding of the extracellular ligand causes enzymatic activity on the intracellular site. So hence the catalytic receptor is an integral membrane for the protein possessing both catalytic and receptor functions. So based on the structural and functional similarities, the membrane receptors are mainly divided into three classes. Number one, ion channel link receptor, enzyme link receptor, and G protein coupled receptor. So in that, enzyme link receptor are a group of transmembrane proteins that contains either the intrinsic enzyme activity on the intracellular domain with the intracellular enzymes. So the types for the enzyme link receptors are receptor tyrosine kinase associated receptor, receptor serine and thorone kinase, and histidine kinase, and receptor tyrosine phosphates, receptor guanylyl cyclase. In that, I'll start from the first, that is receptor tyrosine kinase. So the predominant type of enzyme linked with the receptors is the family of the tyrosine kinase. So the receptor is also referred to a receptor tyrosine kinase. So these receptors have intrinsic kinase activity encoded by the intracellular domain and also referred to as a cytoplasmic tail. So the mechanism for the activation of receptor tyrosine kinase are ligand binding by receptor tyrosine kinase monomers result in the dimer formation. Within the dimer of conformation is changed, locking the kinase into an active state. So the kinase of one receptor then phosphorylates a tyrosine reduce contained in the activation lip of the second receptor, and these forces for the activation lip out of the kinase active site, allowing the ATP bind and resulting in enhanced kinase activity, where this induces the phosphorylation and further tyrosine reduces. And phosphotriosine is a conserved docking site for many intracellular signals, where the transduction proteins that contains SH2 domains. And question number 4, what are ion channel receptors? Explain any one ion channel receptor for the transduction of mechanism. So the ion channel receptors are usually multimeric proteins located in the plasma membranes. So each of the proteins arranges itself so that it forms a passageway from one side of the membrane to the other, where the mechanism are two distinct ligand-gated ion channel appears to play an important role for the visceral sensation. So serotonin receptor and pergonic P2X receptor within the GI tract, mechanical and chemical stimuli triggers the release of 5-HT from the enteroendocrine cells. So this increases in the number of enteroendocrine cells and basal serotonin release, where the similar changes may found in some patients with irritable bowel syndrome IBS because of its abundance and the location in the GI tract and the ability to activate the intrinsic neurons with the enteric plexus as well as the extrinsic efferents. When released serotonin has been widely studied with regarded to the medication of GI motility, nausea and emesis and the pain. So however, the mucosal stimulation in the GI tract activates the primary efferent neurons even after the inhibition of serotonin receptor, hence pointing the presence of other signaling systems, where the visceral sensory neurons expresses P2X receptor, which typically form a heteromultimeric complexes consisting of 3 subunits. Activation of these ligand-gated receptor causes an inward current, thus depolarizing the cells and potentially triggering the action of potential pergonic signaling is well established as being involved in the visceral nopitization, and bladder inflammation in rodents is associated with the apparent changes of the subunit composition for P2X receptors, which moreover differs between the lumbar splenic and the pelvic nerve innervations of the bladder. So the importance of purinergic signaling goes beyond the direct activation of P2X receptors, so in such a way that the ATP and its metabolites are also interact with P2Y receptors, which may be significantly alter the visceral neurons stability. And question number 5, what are the types of interactions? Explain the factor affecting for the pharmacokinetic drug-drug interaction. So there are 3 types of drug interaction: drug-drug interaction, drug-food interaction and drug-condition interaction. So the factors affecting for the pharmacokinetic drug-drug interaction in that absorption, distribution, metabolism and the excretion, where the absorption is interacts with those where the absorption of the object drug is altered, since the oral route is one of the most frequently used to administer the drug, and the net effect of such an interactions is faster or slower the drug absorption, more or less the drug absorption, where mostly frequently clinical significant for these interactions occurs due to the following factors: in that changes in gastrointestinal pH, changes induced by chelation and changes in the GI motility. So number A, that is changes in GI pH. So the absorption in the gut is governed by the gut pH, where the lipid solubility and the pKa of the drug, while the changes in the gastric pH induced by the H2 and proton pump blockers and antacids acting aluminium and magnesium containing formulations have been shown in the significantly reduced drug bioavailability. and number second or B, changes induced by chelation. So chelation plays an important part in reducing the bioavailability of penicillamine caused by some antacids. So these interactions can however be avoided if the interval between the medication is at least 2 to 3 hours. And number C, that is changes in the GI motility, where the drugs with anticholinergic properties like propenthalin or those altering bowel motility like diphenoxylate may affect the absorption of the drug. So metoclopramide on other hand produces an opposite effect on motility and deoxy absorption. Number second, that is drug distribution interaction. So these are those where the distribution pattern of the object drug is altered. Many of the drugs are interact by the displacement of each other binding to plasma proteins. So the drugs are more likely to lead the clinically significant interactions are those that 90% or more protein bond to those tissues having a small volume of the distribution and having low therapeutic index, low hepatic extraction ratios, or those that are administered by IV, intravenous. So the drugs are more likely to displace other drugs from the protein binding site and includes the NSAIDs, phenylbutazone, salicylic acid and sulfonamides, etc. Number third, that is metabolism interaction, where the stimulation of the metabolism increased the activity due to the enhanced enzyme synthesis, which results in increase in the amount of the drug metabolizing enzyme, where the enzyme induction will result in increase the metabolism and excretion and reduces the effect of the agent which is metabolized by the hepatic enzymes. An example, warfarin and phenobarbital. So the phenobarbital increases the rate of metabolism of warfarin, resulting in the decrease of anticoagulant activity and inhibition of metabolism, where the alcohol disulfiram inhibits the activity of the alcohol dehydrogenase, thus inhibiting the oxidation of acetaldehyde and oxidation product of alcohol. This results in accumulation of acetaldehyde and development of the characteristic unpleasant effect for the disulfiram. Where fourth, that is drug elimination reaction, where these are those that excretion pattern of the object drug is altered and some drugs are excreted from the body unchanged in the active form, usually in the urine or via through the biliary tract in the feces. So changes in the renal drug clearance may occur due to the effect of the renal tubular function or urine pH. So the major mechanism for the excretion interactions are alteration in the renal blood flow, that is example for NSAIDs with lithium, and alteration for urine pH, that is example antacid with amphetamine, and competition for active secretion, example probenecid and penicillin, where the forced diuresis. So here I have completed the 5 question and answers for 10 marks, Pharmacology 1 4th semester 2nd unit. Tomorrow I am going to continue the 10 marks from 5 to 9. There are 9 question and answers for 10 marks. So tomorrow I am going to continue with the 6th question. So please do like, share and subscribe to my channel.